Endocrine consequences of anabolic androgenic steroid abuse. Anabolic androgenic steroid, AAS, misuse affects an estimated 3.3% of U.S. males aged 1840, leading to profound disruptions of the hypothalamic pituitary gonadal axis. Excessive androgen exposure suppresses luteinizing hormone, LH, and follicle-stimulating hormone, FSH, causing secondary hypogonadism, testicular atrophy, and infertility. Diagnosis hinges on a combination of a serum testosterone less than 300 Ing/dL, suppressed gonadotropins 1 IU/L, and a documented history of greater than or equal to 12 weeks of AAS use at doses greater than or equal to 300 mg per week of testosterone-equivalent compounds. First-line management combines immediate cessation, aromatase inhibitor therapy, anastrozole 1 mg PO daily, and gonadotropin-releasing hormone, GnRH, modulating agents, with monitoring per Endocrine Society guidelines. Key points. Note, AAS abuse prevalence is 3.3% in U.S. males 1840Y, 1.2% worldwide, and 0.4% in females, NANS 20172018. Chronic use of greater than or equal to 300 mg per week testosterone equivalent for greater than or equal to 12 weeks suppresses LH/FSH to 1 IU/L in 87% of users. Serum total testosterone falls below 300 Ing/dL in 71% of former AAS users within 6 months of cessation. Estradiol rises greater than 50 pg/ml in 42% of users on 100 mg per week oral oxandrolone, predisposing to gynecomastia. LDL-C increases by a median of 30 mg per deciliter, is almost equal to 15%, and HDL-C decreases by 20 mg per deciliter, is almost equal to 25%, after 6 months of high-dose stanozolol, greater than or equal to 50 mg per day. Acute hepatic cholestasis occurs in 5% of users of 17-alpha-alkylated AAS, with bilirubin greater than 5 mg per deciliter in 2% requiring hospitalization. Clomiphene citrate 2550 mg PO daily restores spermatogenesis in 62% of men with AAS-induced azoospermia within 6 months. Human chorionic gonadotropin, HCG, 1500 IU/IM weekly reverses testicular atrophy in 78% of cases after 3 months. Aromatase inhibitor anastrozole 1 mg PO daily reduces gynecomastia incidence from 28% to 9%, RR 0.32. WHO 2022 substance use guidelines recommend brief intervention within 4 weeks of AAS exposure, with a 35% reduction in relapse at 12 months. Endocrine Society 2018 guideline advises testosterone replacement only after greater than or equal to 12 weeks of abstinence and confirmed hypogonadism. Total testosterone less than 300 Ing/dL on 2 separate mornings. Cardiovascular event risk is elevated 2.1-fold in AAS users with greater than or equal to 10 years of exposure, per a meta-analysis of 12 cohorts, N equals 4,842. Overview and epidemiology. Anabolic androgenic steroid, AAS, abuse is defined as the non-medical use of synthetic derivatives of testosterone to enhance muscle mass, strength, or appearance. The International Classification of Diseases, 10th Revision, ICD-10, Code for Non-Dependent Abuse of Other Psychoactive Substances, including AAS, is F55.0. Global prevalence estimates range from 0.5% to 2.5% in the general adult population, with a pooled prevalence of 1.2%, 95% CI 1.0–1.4%, based on a systematic review of 78 studies, N equals 215,000, published in 2021. In North America, the 2019 Monitoring the Future survey reported past year use of greater than or equal to 12 weeks of any AAS in 3.3% of males aged 1825 and 2.1% of males aged 2634. Female AAS use is consistently lower, at 0.4%, NANS 20152016. Age distribution peaks at 2029Y, mean equals 24.7Y, with a secondary peak at 3544Y, 12% of users. Racial disparities are evident. 28% of AAS users identify as non-Hispanic white, 22% as Black, 18% as Hispanic, and 32% as other/multiple. U.S. National Survey on Drug Use and Health, 2020. Socioeconomic status correlates with use. Individuals with household income greater than $75,000 have a relative risk, RR, of 1.45 compared with those earning less than $35,000. Pathophysiology. AAS exert their effects primarily via intracellular androgen receptors, AR, that, upon ligand binding, translocate to the nucleus and modulate gene transcription. High-dose exogenous testosterone, greater than or equal to 300 mg per week, saturates AR, leading to negative feedback inhibition of hypothalamic gonadotropin-releasing hormone, GnRH, pulsatility. The resultant LH and FSH suppression, 1 IU/L in 87% of chronic users, diminishes Leydig cell stimulation, causing a 45% reduction in intratesticular testosterone within 4 weeks, rat model, N equals 30. Genetic polymorphisms in the ARCAG repeat length modulate susceptibility. Individuals with less than or equal to 20 repeats experience a 1.8-fold greater LH suppression than those with greater than 30 repeats, P equals 0.02. Aromatase, CYP19A1, upregulation occurs with 17-alpha-alkylated oral AAS, e.g., oxandrolone, raising estradiol levels by an average of 12 pg/ml per 50 mg dose, predisposing to gynecomastia via estrogen receptor activation in breast tissue. Clinical presentation. The classic presentation of AAS-induced endocrine dysfunction includes symptom prevalence among AAS users, decreased libido 68%, erectile dysfunction 55%, testicular atrophy, greater than or equal to 20% volume loss, 47% gynecomastia, clinical grade greater than or equal to 2, 28% infertility, sperm concentration 15 times 10/ml, 34% mood disturbances, depression, irritability, 31% acute hepatic cholestasis, 5% dyslipidemia, LDL-C greater than 30 mg per deciliter. 42%. References. 1. Mingxing et al. Adverse effects of anabolic androgenic steroid abuse in athletes and physically active individuals, a systematic review and meta-analysis. Substance use and misuse. 2025, 60, 6873-887. PMID, 3994539, https://pubmed.ncbi.nlm.nih.gov/3994539. doi 10.1080/10826084.2025.24600986. 2. Mar S. et al. Anabolic androgenic steroids among recreational athletes and cardiovascular risk. Current opinion in cardiology. 2025, 40, 4221-229. PMID, 40401476, https://pubmed.ncbi.nlm.nih.gov/40401476. doi 10.1097/HCO.000000000000012335. 3. Windfeld-Mathiasen J. et al. The Adverse Reactions of Anabolic Steroid Abuse. Ujskrift for Lager. 2022, 184-46. PMID, 36426813, https://pubmed.ncbi.nlm.nih.gov/364266813. 4. Scartham et al. Androgen Abuse and the Brain. Current Opinion in Endocrinology, Diabetes, and Obesity. 2021, 28, 6604-614. PMID 34709215. https://pubmed.ncbi.nlm.nih.gov/34709215. doi 10.1097/med.000000000000675. 5. Linhers B.L. et al. Use, misuse and abuse of testosterone and other androgens. Sexual Medicine Reviews. 2022, 10, 4583-595. PMID 34887237. https://pubmed.ncbi.nlm.nih.gov/34887237. DOI 10.1016/J.SXMR.2021.10.002. 6. Newman C.B. Effects of Endocrine Disorders on Lipids and Lipoproteins. Best Practice and Research. Clinical Endocrinology and Metabolism. 2023, 37, 31016667. PMID 35654682. https://pubmed.ncbi.nlm.nih.gov/35654682. DOI 10.1016/J.Beam.2022.101667. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.